Bismillahirrahmanirrahim. Hi everyone. I thought it would be a good idea to go over the new ACC Pulmonary Embolism Guidelines that was just released earlier this year. So we're going to discuss not all the elements, but at least those that can be a little bit related to acute hospital medicine or acute medicine. So let's start. I would like to start with this statement, which I totally agree with. The diagnosis of PE is often challenging, with less than 10% of patients evaluated for PE eventually being diagnosed with PE. So basically what they're saying is, if you thought about PE in 10 patients, you evaluated these 10 patients for PE, only one of them probably is going to turn out to have PE, which really shows you how challenging that could be, and I cannot emphasize that more. In the previous video, I talked about chest pain. I mentioned pulmonary embolism as one of the important diagnoses to think about, of course, and I just want to really bring that up again because I think it's very relevant. So chest pain is probably the most common symptom that people will think about PE when they see that symptom in their patients, or also shortness of breath. Wheezes, to some extent, if you have a patient with COPD exacerbation, asthma exacerbation, or cardiac wheezes, but you don't know why they have the exacerbation, think about PE. Unexplained upper abdominal pain in few patients. If they have like lower lobe PE, they can present with upper abdominal pain and discomfort. Patient with unexplained vital signs, unexplained tachycardia, hypoxia, low-grade fever, hypotension. If you don't know the reason, think about PE. Cough and hemoptysis. Hemoptysis often referred to as one of the symptoms to look for when you're like doing the scoring system for PE or DVT. Unexplained syncope or fall or ultramentary status, not very common, but it's known. Unexplained COPD exacerbation or heart failure, we talked about that. And unexplained high BNP and or cardiac biomarkers. And then usually normal chest x-ray. So this is kind of some circumstances, common and less common, that maybe you need to think about pulmonary embolism. Now, why is that? I also discussed this, I think, in some of the lectures about physical exam. Pulmonary embolism, unfortunately, the physical exam might not be very helpful, right? So for example, the likelihood ratio for having tachypnea more than 30 per minute is only 2, which only mildly increases the clinical probability of the PE diagnosis. Tachycardia as well, not very helpful. Left vercinal heave, I don't know how many of us do that anymore. New gallop, mildly increases the probability by 2.2 to 3 of likelihood ratios. Unilateral calf pain or swelling, also not very high. So as you can tell, there's no single symptom or physical exam finding that really makes it probably very high. Then that's why we had all these scoring systems that can increase the probability up to 6 or 7 or 8. And the new modality is point-of-care ultrasound, and I talked about that in one of the videos. It also can be helpful at the bedside. It's specific if you can find the PE abnormalities in your exam, but it has a low sensitivity, meaning patient might have semi-normal POCUS exam, but they still have pulmonary embolism, again, signifying how challenging this diagnosis could be. So what tools you can use to make the diagnosis of PE? So basically, clinical tool and laboratory tools, right? So clinical decision tools that can incorporate assessment of clinical suspicion of PE with laboratory testing are recommended. Clinical suspicion, basically 4 elements. What are the risk factors from history? What are the symptoms suggestive of PE from history? Is physical exam helpful? And the fourth one is, kind of detected with POCUS, point-of-care ultrasound, the relatively new tool. And then the laboratory testing is mostly the D-dimer testing, right? But also the guidelines suggest you think about lactate and cardiac biomarkers, mostly troponin, for risk stratification. So when you're thinking about PE, most of the time you will need a D-dimer. Only maybe 2 situations, based on these guidelines from what I read, that you might not need the D-dimer. One is the clinical suspicion is very high, more than 50% probability of having PE, then in that case, just go ahead and order the CT test. Because even if the D-dimer is negative, but you have high clinical suspicion, the recommendation is still to pursue the diagnosis of PE with the CT or VQ. And the second situation is when you have a very low probability of PE. In that case, for example, if you have like the 8 questions of the PERC tool, Pulmonary Embolism Rule Out Criteria tool, if you have all the 8 questions negative, the probability is very low, and in that case, you might not need the D-dimer. Just pursue other differential diagnoses. So how do you interpret the D-dimer? There's 2 ways based on the guidelines. The first one is the age-adjusted D-dimer level. So basically, you multiply the patient age by 10. And then anything above that is considered a positive test, and then you can pursue the CTPA. So for example, if you have a 60-year-old patient, he has intermediate probability of PE, so you want to check the D-dimer, you checked it, and it came back more than 600 nanogram per milliliter, then you go ahead and order the CT test. The other way is using the years algorithm criteria. Years is basically, this is just a study that was published in the Lancet in 2017 that showed using this criteria, 3 questions. If they are positive, then you have a lower threshold for the level of D-dimer to check using CT. And if all the 3 are negative, which are the clinical signs of DVT, hemoptysis, or PE being the most likely diagnosis. If these 3 are negative, then you can have a higher cutoff, basically 1,000. So if none of these 3 are present, higher cutoff is 1,000 nanogram per milliliter. If 1 or more are positive, then you can have a lower threshold for the D-dimer to test using the CT. So with this study, they found that using this criteria, the years algorithm actually reduces the use of unnecessarily chest CT to check for pulmonary embolism. And of course, what test to order to make the diagnosis of PE is basically the pulmonary angiography CT scan, right? It's still the diagnostic test of choice. Even in pregnant patients, the recommendation is to pursue a low radiation dose CTPA rather than low dose perfusion scintigraphy. And if you make the diagnosis of PE using the CTPA, do you want to order a lower extremity venous duplex ultrasound? The recommendation is it's a class 2B recommendation. If you think that knowing the burden of the thrombosis, if the patient is having a DVT in addition to PE, will make some changes in the diagnosis. For example, if the patient has clinical suspicion of PE and it looks like really bad, then the patient might benefit from interventions like thrombectomy or TPA. Then you probably need to order a duplex ultrasound as well. But at the end of the day, the management might be very similar. So when you order the CTPA, basically not just looking into the presence or absence of clot, but also look for effect of the clot on the, or stress effect on the right side of the heart, right? So the guidelines recommend that you look at the right ventricular over the left ventricular ratio to see if there's any right ventricular enlargement or stress or dysfunction. This is also can be evaluated better with a transthoracic echo. So this is also recommended to do, and there's certain element that you look at. So basically the whole idea is again, not just the presence of the clot, but the effect of the clot on the hemodynamics of the patient, including mostly the right side. And this is probably why the point-of-care ultrasound could be helpful, because some of these elements you can actually detect at the bedside by POCUS. So for example, the right ventricular size, you can appreciate if it's enlarged or not. The systolic function as well, the TAPSE, the tricuspid annual plane systolic excursion. You can just do it visually, or you can actually calculate it if you have more experience with POCUS. McConnell's sign, if you're lucky and find this one, it also could be useful. Paradoxical septum motion is relatively easy to detect by bedside ultrasound, and also the IVC. A lot of POCUS users may be familiar with that as well. But again, the more information will be gained by looking at this element in the echo. Now, probably the biggest change in the guideline, I would say, is this new clinical categories if you remember the previous guidelines, they classified patient with pulmonary embolism based on risk factors into low-risk pulmonary embolism patient, submassive pulmonary embolism patient, and massive pulmonary embolism patient, those with hypertension or with shock. But this is not the case anymore. They suggested this new classification or categories from A to, and this is basically to inform severity and prognosis. So basically, the patient with the lowest risk of having complications or developing complications down the road, a patient with the category A and category B. So patients with category A are those with subclinical pulmonary embolism, meaning we did not really suspect PE in this patient. They're being evaluated for something else, and we discovered that they have pulmonary embolism. So this is the lowest risk patients. B, the patient has some symptoms suggestive of pulmonary embolism, but when you do the risk assessment tools, for example, the pulmonary embolism severity index is less than 85, or the simplified pulmonary embolism severity index of 0, or the Hestia score of 0 out of 11. The Hestia score is basically to detect patients who can be treated as an outpatient. If they have none of these 11 criteria, these are lowest risk patient and they can be managed as outpatient. They don't need to be admitted to the hospital. So ED, emergency medicine physician, can use this tool to kind of send the patient outside. I would say probably very few patients in my experience, again, based on where you practice. So this can also be, can subclassified into B1 and B2. B1, they have subsegmental PE, single or multiple, and P2, a little bit higher risk because they have more proximal, non-subsegmental pulmonary embolism. These two patients, A and B, probably can be either diagnosed in ED or managed as an outpatient, or maybe admitted just for overnight observation because there's the lowest risk. Now, the highest risk patients are categories D and category E. So these are the patients who have like hemodynamic instability, maybe the massive and some of the submassive PE in the old classification. So they have abnormal vital signs, right? So category D is our patient with incipient cardiopulmonary failure. They're about to go into cardiopulmonary failure. Further classified into D1 and D2. D1, they have transient hypotension. D2, they have a normotensive shock. And this can be detected by having a high lactate or having what seems to be an ischemic AKI. These tests can suggest hemodynamic or incipient cardiopulmonary failure. So the recommendation is to take these tests in these patients. And another risk factor that they suggest to add is the R. So some patient might be D1R or D1 or D2 or D2, right? So R basically means they have a positive respiratory modifiers. They needed some supplemental oxygen to support their ventilation or oxygenation. So these are labeled as R, and these are higher risk patients. Category E, basically these are the patients with cardiopulmonary failure. E1, they have recurrent or persistent with cardiogenic shock, and E2 are refractory cardiogenic shock or cardiogenic arrest, again with or without R. Now the one in between is category C, and these are the patients who are symptomatic but they have a higher clinical severity score using the PECI or modified or simplified PESI, or they having one or more of the STS scoring system. So they can be subclassified into C1 if they have normal right ventricle in the CTPA or echo, and normal biomarkers, the BNB or cardiac troponin, and that's why these tests are recommended for risk stratification of these patients. The C2 patient, they have abnormal right ventricle on CT or echo, or two or more abnormal biomarkers, and the C3 was both abnormal. The right ventricle function and size are abnormal, or any of the parameters in the echo are abnormal, and also they have an abnormal biomarker, abnormal BNB or abnormal cardiac troponin, with or without the R or the respiratory modifier. So these are the 5 categories. I think this is really kind of the major change that we have in this new guidelines that we didn't have before. So what to do with these clinical categories? I think they're really just trying to inform the physicians about the treatment, because this is really what we're looking for, right? There's 4 options for medical treatment, and there's 4 options for advanced therapy. So the 4 options for medical treatment include the direct oral anticoagulant and low molecular weight heparin, anticoagulated heparin, and warfarin or coumadin or vitamin K antagonist. And the 4 advanced therapies, thrombolysis or thrombectomy, could be either systemic thrombolysis through alteplase, which is kind of the standard dose or low dose, or catheter-directed thrombolysis. And thrombectomy also has 2 options, mechanical thrombectomy or surgical thrombectomy. So these are the 4 advanced therapies. So again, the treatment and management will be based on these clinical categories and based on the risk factors, right? So patient with category A and B, this patient can be managed with a DOAC, which is basically the medication of choice for pulmonary embolism based on these guidelines. Except in pregnancy, DOACs are not recommended, just like warfarin. So the options you have in pregnancy is heparin. We'll talk about that. And then you assess this patient to see if they really need to be observed for overnight admission maybe, or they can actually just be given the DOAC and discharged from the emergency department or their place of diagnosis. So this is the lowest risk patients. And then for patients who might need to be admitted maybe for observation or further workup to get the echo and other studies, you can start them with DOAC also, but also you can start them on low molecular weight heparin until you do their further risk stratification or management. And one of the things that we talked about that you might consider ordering is the cardiac biomarkers, BNB, troponin, lactate, and then the echo also to evaluate the right ventricular size and function, and also activating the PERT, the Pulmonary Embolism Response Team, which is a class 1 recommendation. So now they really recommend that all hospitals that treat patients with pulmonary embolism, they have this system to kind of help the physicians decide on the management, because sometimes it could be a little bit complicated. Now, only patient was E2, you might consider unfractured heparin. Low molecular heparin is preferred over unfractured heparin to the most part, but for patients who are unstable and you think they might need some interruption of their treatment, maybe the unfractured heparin might be better. But generally, low molecular weight heparin is preferred. And some patients, of course, who are like really sick, they might need like ECMO management for oxygenation. We're not going to talk about that. And of course, D2 to E2 patient might also need some hemodynamic support with vasopressors and or inotropic therapy. Now, the advanced therapy options, the two thrombolysis options and the two thrombectomy options, these can be considered in patients from D1 to E2 categories. This is kind of the highest risk patients. And really the decision about these can be made by the PERT team. And that's why the guidelines highly suggested that, hospitals adopt this to help physicians work up this PE patient and treat them as well. So let's be a little bit more specific here. So which DOAC to use? Is there any preference over the 4 options we have for DOAC in general? I would say, again, I think there's only one recent trial that had like head-to-head comparison between DOACs. I think they did it between apixaban and rivaroxaban. But to be honest, I think most of the time these will be the 2 DOAC that will be mostly used by physicians. I usually prefer apixaban. I put most of my patients on apixaban just because of the data showing that it has lower bleeding risk. Rivaroxaban is a good option too. But, to be more specific, again, we can go over specific situations that discusses this a little bit further. So, for example, if you have a patient that you need to do extended treatment, you think they need anticoagulation more than 3 to 6 months, because they might be a little bit higher risk. So during this extended phase, half dose apixaban 2.5 twice a day or half dose rivaroxaban 10 milligram daily is specifically recommended over a full dose regimens to reduce the risk of bleeding while maintaining efficacy. So you do the full dose in the first 3 to 6 months. After that, you can consider one of these dosages with these 2 medications. However, a patient with obesity, if they have a BMI more than 30, the guideline notes that apixaban and rivaroxaban, again, may be superior in efficacy and safety when compared to warfarin. For patients with severe obesity, BMI more than 50, still both apixaban and rivaroxaban have been found to be equally safe and effective compared to warfarin. How about patients with chronic kidney disease? So DOACs are recommended over vitamin K antagonists for mild to moderate CKD, maybe stage 2 or 3. But what about patients with severe CKD or patient in hemodialysis? The guidelines state that it's uncertain if apixaban is better than vitamin K antagonist for reducing major bleeding in this patient population. Registry data kind of suggests that maybe apixaban is safe and efficacious as warfarin in this patient population, but the data is we don't have like really strong data for rivaroxaban and edoxaban or dabigatran in this patient population. I personally also still prefer apixaban in patients with CKD. In chronic liver disease, DOACs, specifically with mild Child-Pugh A or moderate Child-Pugh B, hepatic impairment or chronic kidney disease, apixaban and rivaroxaban are still identified as safe alternative to warfarin due to their lower incidence of major bleeding. They're not really recommending in patients with advanced liver disease because of increased bleeding in this patient population. Patients with abnormal uterine bleeding, AUB, the guideline highlights differences in bleeding risk for women on anticoagulants. So dabigatran was found to be associated with a lower risk of bleeding in this patient population compared to warfarin. Apixaban shows no significant difference in this patient population compared to warfarin. And for rivaroxaban and edoxaban, they're associated with higher risk of bleeding for these patients. So maybe dabigatran might be a good option for these patients. Again, it's case-by-case determination, so just go over the medical history, liver function, kidney function, all the other risk for bleeding to determine which DOAC may be preferred. Talking about bleeding, the guideline didn't really specify any robust clinical tool or risk factor to assess the bleeding risk. Again, it's case-by-case determination, and some specific patient population that were specifically mentioned in the guideline, including, of course, patients with CKD, especially if they have severe advanced CKD and creatinine clearance less than 30, they have really increased risk of bleeding. Again, for this patient population, maybe apixaban is still reasonable. Patient with primary or metastatic brain tumor, they have higher baseline risk for intracranial hemorrhage, of course, so be careful with these patients. Patient with chronic liver disease, again, we mentioned that DOACs in child view A or B might be safe, but with advanced kidney disease, DOACs generally might not be recommended and might be associated with high risk of bleeding. We talked about patient with abnormal uterine bleeding, where dabigatran is generally preferred. Apexaban is reasonable too. Now, is there any situations where warfarin or coumadin or vitamin K antagonist might be recommended over DOAC? Yes. So, for example, patient with established antiphospholipid syndrome, especially those with like triple antibody positive, these generally have really high risk of thrombosis, and DOACs might still be considered if they have like only one positive antibody, but generally if they're triple positive, warfarin is generally preferred. In patients with advanced CKD, stage 3 or 4, or end-stage renal disease, it's really not very clear if apexaban is better than coumadin. I would say still many physicians will still up to apexaban in this patient population, but you can consider warfarin as well. Breastfeeding, DOACs are not recommended in breastfeeding patients, and in this patient generally low molecular weight heparin or unfractured heparin are preferred, with warfarin as well. Patient with advanced liver disease, child view class C, use of DOAC generally not recommended, so you can consider warfarin in these patient populations. If INR is not too high, you can use warfarin in these patients, but if there is concern about really high risk of bleeding, maybe low molecular weight heparin is a better option. So if you decide to put your patient on low molecular weight heparin, when the guidelines suggest for you to kind of check the activity to monitor the medication and make sure it's working by checking the anti-factor 10 level. So patient with severe CKD, when they have a creatine clearance less than 30, patient with extreme obesity as well. In pregnant patients, the benefit is not very clear, but suggested to also monitor with anti-factor 10A level. Also in critically ill patients, also the benefit is uncertain. So a suggested monitoring protocol is to wait until the low molecular weight heparin reaches steady state level. That's usually typically after at least 3 doses, and then check the peak level. The peak level is the one that's recommended over the trough or random level, and it's recommended to measure the peak level about 3 to 4 hours after the dose. How about IVC filters? The guideline did not really change much about it. Again, there's very specific indications for IVC filters. The primary indications are there's absolute contraindication to anticoagulation. Patient cannot get an anticoagulation because of active bleeding or very high bleeding risk. Or the patient had recurrence despite being optimized on medical treatment and anticoagulation. So the general recommendations, again, routine use is discouraged because they found that it's harmful and does not reduce recurrence and increase the risk of DVT in some patients. Retrievable filters are preferred over permanent filters unless specifically indicated, and the time for retrieval is, if they kind of suggest that maybe between 1 to 2 months maybe after placement, and this is to minimize the long-term complications like fracture or perforation. And the guidelines really kind of recommend that structured follow-up is needed to make sure that these retrievable IVC filters will be retrieved and removed. And they suggested that the protocol should help with that to make sure that this patient get their IVC filter removed in a timely fashion when their need for the IVC filter is gone. How about if you have a patient with unprovoked pulmonary embolism? When and how do you do some testing to check for underlying cause? Why did this patient develop unprovoked PE? So cancer is a big one. You have to think about it. But the general recommendation is really just age-appropriate cancer screening. There is no recommendation to do routine imaging or CT scan or PET in this patient. Just go with the appropriate history, physical exam, and age-guided recommendations by the general guidelines for cancer screening. It's strongly recommended that you do that upon follow-up. There is about 40 to 10% of patients with unprovoked PE who were found to have an underlying cancer within the first year after their PE event. What about thrombophilia testing? So testing for genetic and acquired thrombophilia may be reasonable for patients without major reversible risk factors like younger patient and patient with family history of thrombosis. Although testing obviously does not alter the acute management of this patient, but it can really help you assess the risk of needing lifelong treatment. Although I would say patient with unprovoked PE, they really most likely would need a lifelong treatment anyways, but this risk stratification I think is still helpful for many patients, especially talking about antithrombin deficiency, protein C deficiency, and protein S deficiency, because they're linked to very higher recurrence risk, so it's reasonable to check those in certain patients. When do you test for these thrombophilic tendencies? So you can do the genetic and immunological testing like factor V Leiden or prothrombin gene mutations at any time, because these are not affected by the acute event. But the coagulation-based tests like antithrombin level, protein C level, and protein S level, these are affected by the acute event, and its recommendation is not to test for those during the diagnosis of PE. So delay testing until further time and further evaluation. What if your patient tells you they need to travel, whether in the future or like they have a history of PE in the past, or they have like, a recent PE? So generally for stable patients, early mobilization is preferred over bed rest. This is a class 2A recommendation. For patients who had a history of PE and they have like a long haul travel, like more than 5 hours, there's class 2A recommendation to use compression stocking during the travel time. If your patient had a history of PE and they want to travel, so there's a suggestion, it's actually class 2A recommendation to consider one-time prophylactic dose. I never knew about this, but it's there. So something to think about depending on your discussion with your patient. And for patients recovering from acute PE, especially if they're like category 2C to E, maybe it's reasonable to consider not to travel within the first 4 weeks. This is kind of a class 2B recommendation for these patients. So again, it's case by case thing, and all based on your discussion between you and your patient. So the last topic I want to discuss is if you have a patient who had confirmed PE, new PE, and they have been taking the DOAC, or you think they have been taking the DOAC, what to do? So obviously, investigate the contributing factors. Probably the most important thing first is really to kind of check adherence and compliance. So for example, patients who are taking higher doses of rivaroxaban 15 or 20 milligram dosages, they better take it with meals. If they're not taking that, maybe that's a contributing factor for them to develop a new PE. Is there any other drug-drug interaction that is lowering the level of the DOAC and contributing to medication being therapeutic, and that's why they developed pulmonary embolism? So investigate that. If there is any absorption issues, so apixaban is less affected by bariatric surgery, for example, but if they have surgery of like GI issues or malabsorption, it could be contributing factors. Is there any other underlying clinical risk that increases the risk of just having like really resistant thrombophilia, like patient with active cancer or like triple antibody positive antiphospholipid syndrome? So think about these conditions as well. And if the patient is compliant, or let's assume that the patient is not compliant, so just really do more patient education, do more frequent testing and follow up to make sure that the patient will be adherent to the medication, and don't change the regimen if you think that the problem is that they're just not compliant. If, for example, a patient is taking the reduced dose apixaban or rivaroxaban during the extended anticoagulation time, maybe they just need a higher dose. It's not necessarily to change them to another DOAC. But of course, if the patient is compliant and they still develop a PE despite being an adequate dose, then obviously it makes sense to try a different class of medications in this patient population. All right, very good. So that's it. Please let me know if you have any other questions or have any comments about these guidelines. I hope it was useful, and hopefully to see you in the next video. Thank you. Bye-bye.